there's little that I can say that you haven't experienced and are addressing, but I'd like to share with you what's gone on in our communities, in the nation, in the world in the last 12 weeks, which has changed society fundamentally. So I have biases. My biases, as Marla mentioned, is I'm a clinician. I'm on service currently. I'm an investigator. I desperately want new therapies to treat important infections, and this new infection has emerged. And I'm an editor at a particular journal, the New England Journal, and I have some biases that I hope we get the best stuff, but I realize there's a lot of great stuff in the medical literature that we all need to be knowledgeable about. Approximately 12 weeks ago, or 14 weeks ago, in Wuhan, in China, in November to December, there was this outbreak of pneumonia that we all were, many of us were monitoring because it seemed odd. And it was called Wuhan pneumonia at the time. The ProMed, for those of us who follow it, I'm a ProMed junkie, was sort of had lots of postings and discussion about it. And this Wuhan pneumonia associated with the wet markets, hard to know what to make of it. This was back in December of 2019. Then on January 24th, two sets of publications came out in the New England Journal and the Lancet, identifying what had been going on over the previous 2-3 weeks. And in this report, what was identified was this pneumonia with diffuse infiltrates. A virus was cultured, and EM showed the viral structure, and it was subsequently sequenced, and multiple isolates from different patients in time and space clustered together, suggesting that a novel virus had emerged. It was closely related to the SARS from 18 years ago, closely as about 85 to 90% homology. But it was relatively homogeneous in that the sequences from that particular cluster that was emerging looked the same, suggesting something had jumped into the human to people and was now being transmitted or multiply jumping. In the Lancet on the same day, there were a couple of publications describing clinical features of this pneumonia, which had dyspnea, ARDS, leading to intensive care. There was a hint that it may have spread within a family cluster. And the question was, is there a novel virus emerging that was spreading among people? The virus itself that had been identified, which we're all familiar with, was in the coronavirus family. It's an enveloped single-stranded RNA virus. There were several others. Alpha coronaviruses cause mild colds, and then the SARS, MERS, and the NCOV-19, which was the name at the time, was the one that just been identified and fit into this family. Also around this time and published a week later was a report looking at the first 425 cases. And in this report, I hope you can see my arrow on the screen, the first several weeks of the outbreak or this event in the dark orange, one sees transmission or cases that were largely associated with the wet market. Subsequently, in light orange, were increasing number of cases, but not closely tied to the wet market, raising the specter that there was person-to-person spread as opposed to continual engagement of a reservoir and different individuals getting infected. What's important in this is that this is only 2 months ago. And at this time, and again, this is around January 8th, when it was sort of cultured and then shared with WHO and sequenced. And a week later, the China CDC had PCR testing up and running and had surveillance initiated in the Wuhan area where this pneumonia was being spread and identified. Around this time, the journal and many other journals, JAMA, Lancet, and the larger community agreed that in the setting of this kind of outbreak, we should share information freely and openly. And hopefully that has gone on, and with preprint servers and other vehicles, hopefully information is being disseminated a lot more rapidly, although that has its own challenges that'll come up in a moment. And as you see here, in the last month, there are now hundreds of publications per week that are coming out on preprint servers, which is terrific for information sharing, but incredibly challenging, as many of us are not able to read 1,600 papers in about 1 to 2 months. So different ways to keep track of the literature emerging and assessing quality. But this type of rapid communication, which these events precipitate, I think is very important. And then we as a community have to sort out how best to know what the best information may be to guide our understanding and practice. So this here is from a talk that I gave at a Harvard meeting about a month ago, or less than a month ago. And what I thought was interesting at this talk, as I prepared for the current talk, was the weeks before this talk, the virus, there were issues around the first US case, the science report having solved the crystal structure of the spike protein, which has allowed a lot of investigation to accelerate both in the diagnostic, therapeutic, and vaccine fronts. Initial vaccine going into human testing, characterization of large number of cases in from China. FDA just reevaluating how to allow testing to be done more broadly. In the US itself, there were only 89 cases known at that time, of which 38 may have been locally acquired. The majority were imported. And only 2 fatal cases and suspected cases in several states, but still opaque. This was only about 4 weeks ago. So what have we learned over the last 12 weeks and over the last 4 weeks about this event? There are nearly 800,000 known cases globally. About 10-20% may be clinically severe. 5% may require ICU level care. 1 to 2% mechanical ventilation. 1 to 2% mortality. But do we really know these numbers? The challenge with understanding these numbers, as noted in this pyramid in the upper right corner from Vincent Munster and his group, is that what did we test at the time when we had incredibly limited testing? We were testing the more severe cases, therefore the very mild cases we were not diagnosing, and therefore the challenges with understanding the spectrum of illness, the real rates of severe complications, but also community spread. And the challenge with this virus, as we all know, is when you have a totally globally naive population, then even a 1% severity of illness in a billion people turns into a large number. And I think in part what we are witnessing in our jurisdictions is rapid spread, and therefore perhaps a lower CFR than we realize is an incredibly high number when large number of people are infected simultaneously. Those at risk for complications are older individuals, comorbid, particularly cardiovascular, pulmonary, and those who have higher SOFA scores, LDH, CRP, D-dimer, a variety of biomarkers are emerging as potentially associated with increased morbidity. The complications, as you all know extremely well, are lung injury, which includes ARDS and an odd ventilatory pattern that requires different management strategies. Then there are complications in the kidney, cardiac dysfunction, both direct and indirect. And these are all physiologic injury that we are managing currently. What goes on in children, pregnant women, and other special groups does require more study and investigation, although some reports are shedding some light in these arenas. So the clinical manifestations, This report from Wuhan, published about a month ago, was 1,000 of the first 8,000 cases in China, particularly the Wuhan area. And largely what was described is fever, cough, lymphopenia, and pneumonic injury radiographically. Some had sputum production, some had sore throat, diarrhea or GI symptoms are present, but not necessarily dominant. The large table to the right, I refer you to the paper because there's a long list of associated symptoms, but many of them are occasional and not dominant. What I thought was particularly vexing about this report was that almost half the patients on presentation, and these are skewed to those who are hospitalized, not community individuals infected who weren't sick enough to be hospitalized, nearly half of them didn't have fever, which creates a challenge for case identification, as we all are witnessing. The incubation period was estimated around 4 or 5 days. And as I mentioned, certain laboratory features, the CRP often becomes very elevated, particularly in those who get critically ill. The evidence for a bacterial infection is not present typically, and some degree of liver injury in a minority of patients. The radiology, as you know, is ground glass opacities, although significant proportion of hospitalized patients may not have radiographic evidence of lung injury. The lung injury, as you can see in these sets of images, one sees some GGO, ground glass opacity. In the non-severe cases, progresses modestly at most, while in the severe cases, there is substantial progression. And this leads to a substantial amount of lung injury and primary pulmonary dysfunction in cases in general, and in individuals who have other organ insufficiency, that organ insufficiency may get exacerbated. As one can see in the Holsche report, which was the first case in the US in Seattle, and what I think is interesting about this case that extends more broadly in the clinical phenotype that we're seeing, is one sees some degree of diffuse lung injury, or DGO can be subtle. This particular individual did okay till around day 8, 9, 10, when hypoxemia accelerated and led to increased hospital requirements to support this individual, which suggests there may be a biphasic illness. And I suspect early on it may have a heavy virologic or viral mediated effect, and later on there may be an inflammatory or dysregulated immune response effect, and that may inform us about the pathogenesis and therefore different therapeutic interventions we may want to consider depending where an individual is in their illness. What was also interesting in this report is that the nasopharyngeal aspirate or a swab, relatively high viral load. If you can look at a low CT count in that way, they're not completely correlated, but it is tells you that there was a large amount of virus present. And over the next 8 to 10 days, that decreased substantially, although is still present at illness day 12. Or pharyngeal washes turn negative faster. Serum, urine were negative. Stool also has virus. And I guess the issue of the binding receptor binds to the ACE2 receptors, I'm sure you all know. That's in the lower airway, also in the GI tract, which I think explains in part why we see replication and virus in those two cavities routinely. This cartoon or schematic says a little bit about what may be going on. During the incubation period, the viral load is increasing. There's an initial symptomatic period, which is mild or maybe nil in many, if not most. And then those who develop more significant symptomatology with respiratory distress and dysfunction and hypoxemia, which leads to the hospitalizations and many of the other severe illnesses that we see. This early phase, before one gets clinically symptomatic, is very treacherous from an infection control standpoint. And then the issue of the mild to no symptoms in those who develop mild to no symptoms is equally treacherous in the amplification and spreading phenomenon that I think we're witnessing. This cartoon, based from the Journal Heart Lung article, which I liked because of the concept of the viral phase, where you may have higher levels of virus, and then the host inflammatory phase later on. And the host inflammatory phase may require a different type of treatment given the pathogenesis of the injury. And I think this has to be better defined, but I think this pattern is emerging based on reports from Italy, Seattle, and other jurisdictions that unfortunately are weeks ahead of us. But this pattern seems to be emerging. The case fatality rate seems to be very age dependent, or age is an important risk factor. There are different ways to measure this, but fundamentally, age seems to be an important predictor of significant illness. And I think that's a very important observation that we have to weave into our practice clinically, but also public health-wise, as we try to ameliorate the onslaught that we're dealing with. This report, which came out yesterday, I think, it was two reports, one in JAMA last week and then one in the New England Journal yesterday. This cartoon here, this a plot from the New England Journal paper of 24 cases. The JAMA had 21 cases, so 45 cases from the Seattle area of those who are critically ill in ICUs. And what one sees here is a substantial of ICU utilization, mechanical ventilation, and significant morbidity and mortality. And this becomes a serious, serious illness for those who develop significant respiratory failure, as you know. But these data start to show us patterns that occur over several weeks, because unfortunately Seattle has several weeks to observe this. Children are also infected. There was some discussion that maybe children were protected. I'm not sure that's true, although there may be different differential levels of ACE2 expression by age. But these data from China suggest that children are infected, but they may have a less severe illness. And we know that from many other viral processes. Chickenpox is a nuisance in a kid and life-threatening in an adult. So it's not a new concept that there may be differential severity of illness based on age. However, some children, as well as some younger folk, those younger than 60, do get severe illness and do succumb to this, although that seems to be a significantly lower rate than in older individuals. But I don't think that children are protected or intrinsically resistant to infection, although we need sero studies to better understand the community prevalence of infection. And until we have those, it's going to be very hard for us to know what is the background infection rate in the community around us and even among us healthcare workers. So transmission, I've alluded to this a little bit. We are watching it happen rapidly around us. This report from about 2 months ago, January 30th, in the upper right-hand corner, which I thought was a very important observation at the time, although quite controversial at the time. An individual came from China, the index patient, participated in a work-related set of meetings in Germany for 2 or 3 days, went back to China, and then became ill. And what happened was this individual transmitted to 4 other individuals who wound up transmitting to several other individuals. And this raised the specter that an individual who is asymptomatic or pre-symptomatic or mildly symptomatic to the point where they didn't realize they were symptomatic was able to spread it to colleagues without close contact, with a professional meeting-like contact. And that was an observation which suggested that this might be quite transmissible, like a highly contagious respiratory virus. The issue of when contagion begins is hard to know, because a nasopharyngeal positivity is not the same thing as culturable virus. When the infectious period ends is also unclear, because nasal pharyngeal positivity does not mean culturable virus and still infective. And very often, individuals who are significantly ill may be NP positive for weeks from onset of illness, although very likely towards the tail end of illness, they're not shedding a viable virus, although further research is going on in that space to better illuminate the details. Nosocomial transmission is not a trivial issue. It may not be the driver of the overall epidemic, which is more likely community spread, but it's an incredibly important part of transmission and weakening of our infrastructure. This report in JAMA from a hospital in Wuhan reported upwards of 40% of transmission was nosocomial in nature. It was in a setting where the healthcare system was overrun, and therefore access to PPE and other routine infection control and prevention modalities were not as robust as they need to be. Again, something that unfortunately too many of our communities are facing in the US. And this will potentially lead to nosocomial transmission and further spread. The issue of where does this replicate? What this particular image shows, which is a representative image from a small number of cases reported early on from China, was that the nasopharynx has much higher viral loads if you consider low CT count representing higher quantity of virus compared to throat swabs. And so where one samples is very important to make the diagnosis, to follow the evolution of nucleic acid clearance, and obviously lower respiratory tract is likely to have higher viral loads, but is not as easily sampled for obvious reasons. The viral load when it peaks is not clear, but there are data which suggests that at the time of symptom onset, it may be peaking. So there may be a substantial amount of virus in shedding prior to significant symptoms, again, fitting the pattern of the transmission that we've been witnessing. The incubation period is estimated to be around 5 days. This makes sense to us in what we've seen, and also the serial interval is quite short at several days, which is why the doubling time we've witnessed to 38 cases a month ago to 100,000 plus cases in the US currently. It speaks to the nature of the doubling time. The epidemiology in key populations, and I think this is a very, very important population, which is our long-term care facilities. This is a report published a few days ago, which builds on the MMWR report from several days before that. And between the MMWR report and this report, the case fatality rate had doubled. This is part of the investigation that's gone on in Seattle. And what I think is important here is that in a long-term care facility, one has 100 residents infected pretty rapidly, as well as healthcare workers and visitors. Half of the residents infected get hospitalized. A third of them succumb to this. And that's still ongoing as this event is not resolved. And one just sees in the graphic the speed with which the cases occurred. And then one sees that this means there are 34 senior citizens who wind up in our hospitals, ICUs, on ventilators. And when one gets on a ventilator, one does not come off so quickly. And that creates a substantial strain on the healthcare system. In addition, an image here on the right, the figure 2, shows that there's a lot of trafficking between facilities, between patients, care providers, other workers, supply chain, and we need to think about this because if we do not protect our high-risk facilities, they will get infected, as we've seen on the cruise ships. We'll have massive transmission and tremendous health need because this population is likely to have a higher attack rate for severe illness, and then our acute care facilities will be challenged with caring for this level of illness. How does this get around? Not completely known. And in fact, this report from Vince Munster's group, again in the Rocky Mountain Labs, doesn't answer that question, but I think it gives important insights into how SARS-CoV-2 may survive in the environment. It's a artificial model where the SARS-1 and SARS-CoV-2 are generated. They take the virus, they then aerosolize it, and then they see how long it lasted in the environment. And it lasted for different hours to day or two on different substances, be it copper, cardboard, stainless steel, plastic. Again, it's an artificial model, but what it does suggest is that this virus can last for some period of time, probably not a very long period of time, but some period of time in the environment, depending on the burden that's being shed by the individual who is ill and therefore creating large numbers of virus. What I think is an important observation from this, from my perspective, is that SARS-1 18 years ago, we were able to contain that. But SARS-1 seemed to be lower respiratory tract. You didn't start shedding until you were ill for many days, often 4 or 5 days, so that the environmental contamination was more modest. But these data suggest that the two viruses seem to behave in a similar way in the environment, but there may be differences in the biology in vivo that alter the transmission dynamics. With SARS-1, lower respiratory tract, days of illness before you have high viral load, other than the super spreader events. With SARS-CoV-2, it appears that we see high viral load in the oropharynx, in the upper airway, often days before you become ill, and often in individuals who aren't ill. And that then challenges our case finding and containment. Whether there are higher viral loads and longer shedding in those who are more severely ill can be debated. I'm not sure this is a driver of transmission, but there may well be super spreaders for SARS-CoV-2. It's just hard to observe that when there's such massive transmission likely going on broadly. Treatment, which is something we in the acute care environment are desperately seeking and in need of, given the illness in our patients. As you know, there are no specific antiviral therapies. There just aren't, despite popular press and other internet claims. I am not aware of compelling evidence that establish any specific antiviral therapy, and I think we need data to drive our decision making, as no therapy is without risk, and we need to understand the risk benefit and the amount of efficacy. Obviously, it's supportive care, airway support, oxygenation, ventilator, minimize concomitant injury and superinfection, which probably doesn't play a significant role, although I'm sure in many cases there will be issues to be addressed there. The role of the anti-inflammatory agents, I think corticosteroids largely are not considered useful in this setting, although there are debate in that arena. With SARS-1, it looked like it did not help and may have allowed amplification of virus. The issue of targeted agents for the inflammasome, particularly the IL-6, is very intriguing. There are high IL-6 levels in our severely ill patients, often deep into illness, 1-2 weeks. And whether IL-6 blockade is beneficial is under active investigation, but there are reasons to believe that this might turn out to be an effective therapy. The role of NSAIDs, I think, is incredibly controversial and unclear. What to do with off-the-shelf agents, I'm going to talk about in just a minute, from Kaletra to chloroquine, hydroxychloroquine, penciclovir, ribavirin, particularly the first two are being heavily looked at, and then there are experimental medications that are also being looked at. The ACE-ARB discussion, I'm aware of compelling arguments from very senior individuals on both sides of this equation, with in vitro data selectively chosen to support a point of view. I am not aware of clinically directive data that unravels this challenge, given the pathway that the virus utilizes and how these agents manipulate that pathway. And then vaccines are on the horizon. They're being developed faster than ever before. However, they're 6 months, year and a half probably 6 to 12 months for us to see evidence of activity, 12 to 18 months before we might be in a position for them to be deployable, probably a little bit longer than that. So lopinavir, ritonavir, Kaletra, off-the-shelf agent, very active to treat our AIDS patients. Our colleagues in China were able to launch such a study within days of the epidemic. So by about January 18th, when, as I mentioned before, and so they were able to launch this study pretty quickly. They were able to enroll about 199 individuals with severe disease, 25% mortality in the standard of care alone group. And what one sees in their primary outcome is no clear difference in Kaletra standard of care versus standard of care alone. An important element in this is that the viral load, if one looks at the SARS-CoV viral load, the standard of care group and the Kaletra group do not look like there are meaningful differences to the decrement in viral load over time associated with treatment. There was a subgroup that suggested that maybe in those patients who were diagnosed earlier, less than 12 days onset of illness, might have a little bit of a hint of benefit, although it's a post hoc subgroup analysis and the curves are not compellingly different, although there might be a hint here. And there was a slight difference in mortality, not statistically meaningful, small number of cases. So overall, it's hard to know where lopinavir or ritonavir fits in. However, these data, in my view, do not suggest that it's highly active. Whether or not it might be active in a subgroup with a different clinical phenotype is worthy of study, and the WHO has a large global study assessing this among other regimens to treat this infection. Hydroxychloroquine seems to be viewed as highly efficacious and is being sought by many, where my understanding is many pharmacies are now depleted of their supplies of this agent, even in jurisdictions that don't have many cases. Here is the only RCT that I'm aware of that's published in the Chinese literature. One can get a translation of it, and it's only 15 per group. They receive other concomitant therapies, and there was no clear difference with hydroxychloroquine standard of care versus standard of care in these mild ill individuals. So I'm not sure these data demonstrate dramatic effect. They're encouraging, intriguing by subgroup analysis, but overall incredibly limited and small. There is this report that I'm sure you're all familiar with from our colleagues in Marseille. And in this report, particularly the hydroxychloroquine azithro group, which had 6 individuals, they have a follow-on report that's in a preprint server. I'm only sharing with you articles published in peer-reviewed journal, but there are additional reports on preprint servers. But in this report, the control group was not really RCT, where they were open label, randomized. There are control groups that are sort of matched post hoc, and there are small numbers, like only 6 individuals receiving hydroxychloroquine azithro. So I find these data incredibly difficult to interpret, and in my view, they're more a series of anecdotes rather than well-controlled data that inform us of a regimen that we should be using. So at this point, I don't think there are data for hydroxychloroquine that establishes activity of it against SARS-CoV in the human model. There are preclinical data. There are small studies that are suggestive at best. Favipiravir is another agent that has been looked at. It is approved in Japan, not approved in this country. Here's a small study of 35 who received favipiravir versus lopinavir ritonavir. It was an open-labeled, controlled, not clear that it was actually randomized versus concomitant sort of controls, and suggests maybe there is a more rapid clearance of virus in the favipiravir group than the Kaletra group. I think this warrants further study. These data are provocative at best, in no way definitive, but do suggest that maybe there is activity, and hopefully future work will help enlighten us. Convalescent plasma is a age-old approach in infectious diseases. During the initial Ebola outbreaks in '76, one of the first things that was set up was convalescent plasma in case any of the investigators investigating the outbreak became ill, they might have an antidote. In this report of 5 individuals reported a few days ago in JAMA, critically ill individuals using a new titer of greater than 1 to 40. Speaking with Peter Marks at FDA, probably 1 to 320 or a higher titer may make more sense, although we need more published data in this space to determine what to do. But one sees a drop in the viral load or elevation cycle threshold, drop in viral load, some improvement in parameters. But again, it's 5 individuals critically ill, uncontrolled, but an encouraging approach that makes some degree of biologic sense if one thinks antibody is an important parameter in control of this virus, which there's good reason to believe that it's likely important. Speaking of control, I think we have a lot to learn from our colleagues elsewhere, Singapore, South Korea. This set of images here show the evolution of the outbreak in South Korea. Rapidly spreading, they rapidly increased testing with massive testing, case identification, and appropriate restrictions of movement to prevent transmission. And as we know, to date, South Korea appears to have been able to control spread, although obviously the threat is ongoing, and massive testing, in my view, probably played an important role because they were rapidly able to identify individuals who are contagious before a substantial number of additional individuals became infected. So I think that we need to think about how do we bend the curve or really crush the curve. And we need to think about massive testing, social measures to decrease transmission. I think that if we can decrease transmission, that's the best way to restart our economy. We have to protect each other and our frontline workers with PPE, with massive testing to know who's infected so that we can manage our own lives and our families, as well as take care of our patients and run our health centers. And then we need our countermeasures, and we need community support to support us in doing this. I think that the issue of how to think about massive testing, I think there are different challenges in New York City or Boston than in other jurisdictions that may not have widespread community transmission. In the areas without widespread community transmission, hopefully through vigorous public health intervention, it won't get out of control. For those of us, such as Boston or New York, we need massive testing, in my view, to know who's infected so we can properly determine treatments and isolation and minimize further transmission in our healthcare settings, and also decrease increasing number of ill patients in our communities, particularly in our most vulnerable parts of the community, such as our senior centers, where if they get infected, I worry that leads to a dramatic increase in ICU needs, given the high-risk population in those environments.